Good morning and welcome to MED210. This is week 7, September 15th, Wednesday morning, 9 a.m. What is due today? Due today is, since it's week 7, task 6, discussion 6, lesson 6. We will doing week 7 items. Now, week 8, this is part of this public service announcement. Week 8 and week 9, we are on campus. I repeat, week 8 and week 9, we are on campus. There are on-campus mandatory laboratories. And I have to repeat, mandatory. So if you're not there, I have to place you as absent. But it goes, give me a call if you can't make it. And I'm sure it's a legitimate, a legitimate reason, but the policy is mandatory. This is a hybrid class. So there has to be some on-ground component. And it's laboratory. This is the cool stuff. For week 8 and 9, I'll be posting videos for week 8 and 9. And we'll be meeting on campus, 4th floor, Alexandria campus, Health Lab 1. All this other information will also be included on announcements as well. And if you cannot make it, I need to be notified today formally via email and why. Okay. And yes, formally. Many of you like to call, but we have to document why the student can't come in. Now, if you're absent 2 consecutive days, it won't kill your grade, or you won't be removed from the class. So if you can't make it, you can't make it. Usually the reasons are either work or COVID safety reasons. Now, let's start the show, and I'm gonna put more in the announcements. And if you have any more questions, of course, shoot an email, shoot a text, and I'll answer your questions. So what are we doing today? Task 7, it's special senses. Now, if you look at the homeostasis model, which you should be familiar with because it is the last chapter of what do you call that? Of Anatomy and Physiology 1. So let's look at this. There you go. In order for us to maintain homeostasis or balance, there has to be some sort of stimulus to tell us that there is an imbalance. And those are your senses or your sensory. Because remember, sensory is ascending nerve tracts. So there has to be some sort of thing that detects that something is wrong. And that's where your special senses come into play and your sensory system. So you have a sensory system that receives messages from the outside world telling you, hey, things might be a little off. Your control center is always your brain. And the brain then relays what to do to get you back on balance. And that's your motor or your effector pathway. So this pathway is also known as sensory. This pathway is also motor. This pathway is also known as afferent, AFFERENT, right? Or afferent pathways to your brain. And then efferent, effector pathways, motor is the thing that's going to happen to change the response. So for example, I'm feeling a little cold. That's my stimulus. That's my my sensory receptors on my skin tell me that it's cold in the room. So what will it do? Send messages up to my brain, and the message will tell me, hey, it's cold. So my brain will tell me, you know what? I need to put on a jacket. So I get up, my motor, and I go to the closet and I put on a jacket. Or I start to shiver, and that's motor. That's your muscles. The erector papilla muscles on your hair will stand up. They say in theory to, decrease, wind chill on your skin. But, if any of you ever been outside without a proper jacket, how much that's worth, but that's what the textbook says. So you could see here that we need not only sensory ascending fibers to give us messages to the brain, we also need descending fibers or descending tracts or descending wires, descending nerves, right? All synonymous, right? That will affect a change, right? So that's all that's happening in your body at any given time. And it should quite amaze you because most of it, you have no idea that it's going on. So that's chapter 14. So let's look at that in our textbook. Okay, close this out. What's going on here? Table of contents and chapter 14. So sensory perception. Now, if we look at the word perception, now this is going to freak you out a little bit, or maybe it won't. Freak me out when I first learned it. That the things that we are sensing right now, you're looking at the screen, you're hearing my voice. That is not my voice. And what you're seeing is just a bunch of light rays. It is your brain that takes that information, that raw information, and paints a picture for you. So that should make you think a little bit about hallucinations. And have either of you ever, like, late at night, you maybe heard a voice or saw something, and maybe it didn't scare you, or especially those of you who are parents, when you're away from your children, don't you hear your kids every once in a while? Am I the only one? I hope not. And it's because your brain did what? It took sensory information and then did what? Process it wrong. Like, how many times did you think that someone was moving? Like, maybe you were tired, or you were on your screen too much. And I'm here alone in my little basement bunker here. And every once in a while, I have these mirrors to the side and behind me that are, I don't know, they're part of the closets, but every once in a while, especially late at night, especially when I'm tired, I could have sworn something was moving behind me. And I get a little freaked out. Well, I calm down because I know that it might be a misinterpretation of my brain that something was moving around me. Now you could see now that you know the control center is your brain, you could see now the very importance of understanding this pathway, especially when you're dealing with your psychiatric patient, especially a patient with psychosis, OSIS, abnormal condition of the psych mind. They could see and hear things that aren't there, and for their reality, it is real. So as a little bit of clinical advice, treat it like it's real. Take their fears as if they're reality. Now, don't join them in their reality, of course, but it goes, understand. I always tell this story about, I had a patient, I think he had a tumor or something. Well, whatever was going on, because after we stabilized him, we brought him to neurology. Because no history of any drug or alcohol abuse, 28-year-old male, he was responsible, went to work every day, has family. So, but he started seeing things a month prior to consultation. And on this particular day, his family brought him into my ER. Well, not my ER, I just call it my ER, emergency room, because he was very paranoid. He was very scared. Now, I could sit and dismiss him, right? So, for example, he was in the waiting room running back and forth, scared because he said the dragons found him and were coming out of the ceiling. So, of course, unit secretary is telling me that I was in ER, and unit secretary is telling me, Dr. Garais, your patient outside is pacing. He's freaking everybody out. Can you do something? Can I call security? I go, no. Let me see what the hell's going on. So I talked to the man. He tells me, of course, dragons. So this is what I did. I brought him into one of the other side rooms of the ER, and I told him, okay, this is a special blanket that will temporarily protect you from the dragons so that they don't see you. So he goes, do you think that'll work? So of course, I just put a regular blanket over him. I put him in a nice quiet room, turned the lights off, and left him under there in the blanket. Well, another nurse was like, well, I need this room, get out. What the hell are you doing in here? And he says, well, Dr. Garais said I could stay here. He's protecting me from the dragons. So this nurse started doing what? No, get out. Long story short, what do you think the man did to her? He assaulted her. Okay, because he was so scared, and also she did not see or didn't even read his chart or anything, that his perception of reality was very, very different. And by the time I got to her, she's already got slapped and got hurt. And how many times has that happened to me, that I did not take into consideration the central nervous system or my patient's brain. Okay, and I didn't because there's something called ABCs in both clinical world and in education. Everyone sees the B, the behavior. Everyone also sees the C, the consequence of their behaviors. But a lot of people really don't want to see or don't want to investigate the A, which is the antecedent. Ante in medical terminology means before. So what happened before? So when someone's screaming at you, screaming their head off, or really, really scared, or just acting abnormal, one of the things that you have to consider is what? Mental defect or mental disease or mental disorder. So you have to, and mental is pertain to your mentum, your mind. Where's your state of mind? So that's something to consider, because all that sensory receptors do is take energy and then just convert it into electricity, into things that the brain can understand. So for example, here you have your typical nerve cell, and it has dendrites, and this is the axon. And you could see these little things, these light blue things here, that's insulator. That's essentially fat. And the signal travels over this fat and goes boop, boop, boop. And it's called saltatory conduction. So in the nerve cell or the neuron, it's pretty fast. So when you're looking at something like a specialized receptor cell, like rods and cones, and this is a rod that's in your retina, which is your eye doesn't really see anything. Your eye just picks up light energy and then converts it to electricity, also known as the action potential, and then they run it through the nerve cell, and the nerve cell connects to the next one, all the way up the chain, all the way to your brain. And it is your brain that interprets. I used to be part of a school that had a criminal justice program, and I loved it because many times the criminal justice professors would invite me to their laboratories. And one of the laboratories that I found very interesting was, how to take down, witness, what the witness sees. And I'm like 5'0", and one of the scenarios was I was supposed to come in, rob one of the students, and not even in 30 seconds, and just leave. And then everyone was supposed to write down exactly what happened. Of course, everyone has different perceptions. So there were people who were saying that, oh, definitely the perpetrator was 5'10" and a black male. Huh? Some of them said, no, it was a chubby female. And I'm like, what? No, he goes, I'm 5'0". And he goes, they should have at least he goes, at least registered in the short time that I was male, that I'm short, right? And some of them even said I had an accent. Okay, maybe a New York City accent, but you could see how everyone's perception is different. Everyone's brain is different, but the sensors only pick up energy, and they convert the energy to the action potential, which is the electrical signal that goes up to the brain. We have chemoreceptors. in our body that detect chemicals. How does your body know that it's low on salt? Right? How do you know what you're tasting or what you're smelling? We have osmoreceptors that also tell us how's our body fluids. Are we running a little bit short? Are we running? Am I have too much fluid? We also have nociceptors. Those are pain stimuli. Those are really neat because pain is a lovely thing. It tells you exactly where the trouble is. That's why I can't stand. That's a little bit of a superlative. In pediatrics, when you're interviewing, especially toddlers, it's so hard because when you ask them, where does it hurt? Hurts everywhere. How about your hair? My hair hurts. How about your left ear? Yes, my left ear. And you're like, wow, okay, I'm having real trouble here, right? But once the child tells me something hurts, then I know that there's something wrong. We also have mechanoreceptors, okay, which tell us body position. Right? How do you know you're upside down? How do you know you're right side up? How do you know you're tilting your head to your left? Try it right now. Close your eyes, tilt your head to the left. You know inside your head that you're not upright. And those are mechanoreceptors. But have a couple of drinks. How well can your brain now interpret those signals? The signals are coming in the same as they always were, but now they're different, right? Thermoreceptors, we just talked about that right now, right? I'm sensing what? I'm hot, or I'm sensing that I am cold. So these are the different types of receptors and what they detect. But remember, all of them are transducers. They will change whatever energy that they are detecting into an action potential or an electrical spark that will send a message to the brain. Now, special senses are what we're going to be talking about today, which are specific. So the first one we're going to talk about is gustation, or the gustatory sense, and that's taste. The thing about your tongue, it has all these little bumps on it. Have you ever really looked at your tongue in the mirror? If we were in lab, and actually we can in lab, I'll save some of the piggies that the Tuesday evening group are going to cut up, and we could really look at, if you look at really closely to your tongue, they have different types of little bumps or little mini fingers that are popping up, and they're called papilla, or papillae for plural. And these papillae, they have taste buds, which are actually hair cells, and they detect, and they are chemoreceptors. They detect different types of chemicals, and then they send a message, right, through these nerve cells, and they're colored yellow because, you know, nerve cells have, we showed a minute in the dendrites, not dendrites, the axon, that it's all covered in fat. This is a bundle of fat, and it acts like an insulator so that the message can go really fast. So if you taste something nasty, you're going to know it when? The second you put it in your mouth. And if you taste something awesome, you're going to know it. And there's different taste buds, and there's different sensory areas on your tongue. And let's look at this other diagram. We used to have pre-COVID these what do you call that? With these labs where, you know, we make the students taste certain things, and we tried to figure out, and we tried to map this out. But of course, it's COVID now, we can't do that kind of thing. But if you look at it, on the tip of your tongue, you have sweet and salty. On the sides, you have sour. And on the back is bitter. And in the middle, it's that thing that the Japanese called umami, umami. MI, and that's the savory part, or when things taste good. But good taste and good food is not just one single thing. It's a combination of things. And I always cite like a good chocolate always has, of course, sugar, but it has a little bit of salt. You can also notice that the sour here is on the sides. And when you eat something sour, you start salivating. And guess where all the majority of the salivary glands are? They're underneath the tongue on the side, and they're here in the buccal cavity right here on the side as well. And in the back, I always remember back, bitter. And I always remember, when you're drinking a beer, what do? You throw it back, throw it to the bitter area, because beer is bitter. And I remember when I was a kid, I used to hate that taste. But remember, over time, your palate, well, not really your palate, which is your tongue, it's your brain likes different things. Like I used to love spicy stuff when I was in my 20s. I used to love going to the hottest Thai restaurants and the hottest Indian restaurants. And I used to relish in, very, very spicy foods. I can't do that now. Now that I'm older, spicy foods totally turn me off, and I don't care for it. Things change, and the perceptions change because the brain changed. But the papilla here, the hair cells, which are chemoreceptors, they don't change. It is the brain that changes over time. Now, gustatory and olfaction, which is smell, they run together. We know that, when you have a really bad cold and you try to eat your favorite food to make you feel better, it still tastes like nothing. It's because both of them are in conjunction with each other. That's why you start salivating when you smell really good food, right? When I teach at night, and my mother or my wife or one of my kids are cooking something, I start salivating it, because guess what? Oh, I forgot to mention, these taste hairs, okay, the hair cells here need to be in an aqueous environment. That's why if you ever, have you ever like eat way too many crackers? It's almost like eating sand. You can't really taste anything, right? But then you start tasting the saltiness when you start, having a little drink of water, or maybe when the saliva kicks in. Same thing for your olfactory. And you could see, here's your nose, here's your cribriform plate. Let's enlarge this. And it goes right up to your brain. And guess what? The detectors are hair cells as well. Where are we? Okay, as you can see here. So you inhale the air, and the air has to be what? A little bit moist. And that's where your mucosal lining comes in. Have either of you ever been in the desert or a dry place?
Yeah.
Yeah. When I was in the Sudan, I was standing on like a pile of donkey and camel dung. I wasn't the only one. It was like 4 or 5 of us until Sergeant came and said to me, he goes, "Hey, do you guys know you're standing on a pile of stuff?" And I go, "Huh?" I look down. I'm like, "Oh, nasty." I didn't smell it at all. But then what happened? I got inside the transport that has a little bit of kind of air conditioning, right? Then did we smell it? You betcha. And you're like, ugh. And also, if you're ever wondering why people snort drugs like cocaine or Xanax or, whatever stupidity you want to put up there, right? You could see how that drug can go right here and then go right into your brain. And oh, by the way, that powder acts like an irritant and also kind of like a sandblaster. So that's why over time, the cribriform plate starts to wear away. Some of the arteries and veins get exposed, and that's why your patient has nosebleeds. And again, if you understand how things work normally, pathology is easy to understand. And you could now see it's like vapor. The inhaled air, when you have a nice cup of coffee, it's vapor and it's in an aqueous form and it's traveling up into your nose. So that's why, You know, when you want something, when you're eating good food, you're not only tasting it, you're smelling it at the same time. And that is the olfactory system. Anosmia, when you can't smell stuff, it could be a multitude of things. But one thing, like if everything's normal with their nose, and if there's nothing else wrong with them, we're gonna start thinking a neurologic, a nerve problem or a brain problem. Audition or hearing. Let's look at how we hear. Right now, put your mouth by, put your hand by your mouth and just say something, anything. Do you see how there's a vibration and it's kind of like shaking your skin? Hello, hello. Okay. So that's what happens. What does your ear do? It picks up sound waves, and sound waves will hit your tympanic membrane. Now, your internal auditory canal here also has a little bit of wax called cerumen, CERUMEN, to prevent any foreign body getting in here. But you know, you have to clean your outer ears. And remember, don't be one of those people shove a Q-tip all the way in here, because you could damage your tympanic membrane, which is right here. Also, this auricle part, the outer part, has no real purpose except for earrings and holding up your glasses. Studies have already shown that patients without an auricle, also known as your pinna, PINNA, don't need it to hear. But if you start having impacted cerumen or excessive amounts of cerumen here, or sometimes a bug, it's kind of common, semi-common, especially in an urban environment. Roaches like going in there. You know, they like dark places. If you're an outpatient in ENT, you'll see that a lot. It's shocking at first, but then after a while, you're like, you know, it's amazing what you get used to. So you have the external ear. Now, all the really important stuff is in the middle and inner ear. Doesn't that sound like a theme? Whoever built us pretty smart. So the sound waves come in here. They rattle and they move that tympanic membrane in the same way that your voice moved your hand a little bit. So that's why the tympanic membrane is kind of delicate, and we don't want to stick any foreign body in here and ruin that. Now, the tympanic membrane will vibrate. It will then also vibrate. So it's going to go from sound waves to mechanical energy real quick. And then it'll vibrate the tympanic membrane, and then you have your three ossicles, or the smallest bones in your body, your malleus, incus, and stapes. And malleus is Latin for hammer, incus is Latin for anvil, and your stapes is Latin for stirrups. So hammer, anvil, stirrups, right? I guess they were into horses or something, whoever figured this stuff out. So this vibrates, the three ossicles, the malleus, incus, and stapes vibrate, and then that vibration goes through this round window and then into the cochlea. Okay, now guess what the cochlea has? I think there's another picture in your book, but show this part. It's a good. Okay, let's look at this one, if it'll let me. So that vibration goes through the oval window, and you'll see this vestibuli means like a vestibule or a room, but there is endolymph in here. There's fluid in here. And that vibration from your eardrum to your ossicles to the oval window go into the cochlea. And in the cochlea, that vibration is now going to move these hair cells, also known as stereocilia. They'll move it in a way that will then convert that movement into some electrical activity that will go into your cochlear nerve. So again, you are not really hearing my voice. You are hearing your brain's interpretation of my voice. And the nerve that, which is your vestibular cochlear nerve, has two functions, or also known as your cranial nerve 8, and they're typically written in Roman numerals. Your cranial nerve 8 is this, all these nerves here. And this is the cochlear section of your vestibulocochlear nerve, or also known as your cranial nerve 8. And your cochlear nerve is part of that nerve that deals with hearing. It just sends signals of those vibrations to your brain, and it is your brain that interprets what you're hearing. Have you guys ever seen those TikToks or maybe YouTube where they show you a word, and depending on what word you're seeing, that's the word you're hearing? You know, there's these little auditory tricks. Well, yes. It's the same thing. It's because your interpretation, of course, you saw it with your eyes, so it like presets your brain, and that's what you're and that's what you're thinking. Actually, a lot of marketing, a lot of advertising is done a certain way, so that because they know the science of how you hear things and how you see things. And it's not really what you heard. It's not it's not really an exact interpretation. It is the perception. It is your brain's idea, right, of what you think is going on. That's why, again, with that that witness laboratory class in my previous life as in this other university, another class was called surveillance. The surveillance was so funny because even if you got everything on tape, the level of misinterpretation, because everyone's brain is different. But what could I ask you on exam? Could I have this? A, B, C, D, E, F, G? Sure. Could I ask you this nerve, the cochlear nerve, what's it used for? And you'll tell me for hearing, for audition. Now, the vestibular nerve is something else. If you look at here, this is your vestibule. There's these semicircular canals. Let's see if the vestibule is for balance. So let's look at balance. Okay. Just like your cochlea, there's fluid in here as well. Okay. And this is your vestibule. And if you notice, the vestibule has one loop that goes this way, another loop that goes that way, and another loop that goes diagonally. Hence, 3 dimensions. So there's water in here. So if you turn your head to the right, all the water will move where? In a certain section. And then it will activate these otoliths. They're also hair cells, and it'll do what? It'll send a signal, hey, that's where your head is at. So tilt your head to the right, all the fluid is going to go to the right, and it's going to tell you what's going on. Tilt your head to the left, up, down, right? It will tell you your position sense. And that's the function of your vestibule. And then it sends the message to the vestibular nerve. Now, what happens when you have vertigo, or what happens if I put you on a merry-go-round that goes way too fast? What will happen to the fluid? It'll start swirling around. And what happens to water after you swirl it around? Like I have a water bottle next to me and I'm swirling it around. Does the water come to a complete stop? No, it swirls around a little bit more long after you stop. And that's how you get dizzy. Now, do either of you drink, or maybe at one time, maybe drank too much? What happens when you drink too much? Alcohol is a depressant. So how many times have I drank too much and I put my head on the ground, and then a second later, the entire room then moves, or the room is still moving after I've stopped. The room isn't moving. I'm not moving. Neither is the fluid moving, but the message in the vestibular division of the vestibular cochlear nerve, also known as your cranial nerve 8, is slowed down, and then your brain will perceive it very differently. Okay. Here's another way to look at your vestibule. See, one's going up and down, the other one's going side to side, and the other one is going diagonally, hence 3 dimensions. And that's how your mechanoreceptors know if you're upside down, left, right, and whatnot. Somatosensation, or just simply sensation, is touch. And we already talked about the nerve endings in the skin. You also have mechanoreceptors as well, right? They tell you, you know, in your epidermis and dermis, if something is touching you. But the big one is of these two, Meissner's and Pacinian. Meissner's, tactile, is in the papillary dermis. It's fingers and lips, and it's very sensitive because it's sensitive to light touch, around 50 hertz or 50 cycles per second. That's what a hertz is. So it can send a very delicate message 50 times in 1 second. Now, but your lamellated corpuscles, also known as your Pacinian are deep. They're in the sub-Q or subcutaneous tissue. 250 hertz, deep pressure, high frequency vibration. So it's deep touch, right? So deep touch, Pacinian, light touch, Meissner's. You also have hair follicles, muscle spindles, tendon stretch, and tendon is your Golgi tendon. So there's wiring in all your tendons to tell you, you know, how much your tendons are stretching. So that's sensation or touch. And remember, it's in the skin. So if I burn my skin or burn a full thickness burn, I will not be able to sense anything. That's why in burns, especially third and fourth degree or full thickness burns, feeling is not, or sensation is not my worry. Remember, our worries on burns are infection and hydration status of your patient. Now, let's look at vision. Let's look at this eyeball. Your eye has a whole bunch of muscles. Let's look at, and they're called your extraocular muscles to move your eyes around. And your eyes are moved together in tandem. And I'm going to tell you why in a minute. Like, you know that when you look to your left, you don't have your right eye looking at your right and your left eye, or, you know, unless something's wrong, right? Let us look at first the internal structures of the eye. And in laboratory, we're going to open up, I don't know, sheep's eye. I was trying to get the cow's eyes, the really big ones, but they were out of stock. So we'll just use the little ones. So when we're doing our dissection, what are we going to be looking for? And also I'll be explaining why these things are the way they are. So you have 2 chambers in your eye, or 2 rooms. The front room is called your anterior cavity, or your aqueous humor. Aqueous means watery, humor means fluid. So in the front part of your eye, it's water. But in the back part of your eye, that's your vitreous chamber, it has like gel. It's like a jelly-like substance. Now, why in heaven's name would you need that? Well, here, all this here is your retina, all this layer here in the back. And it's connected into your cranial nerve 2, also known as your optic nerve. Now, everything is, the function of your eye is to focus all the light rays onto this retina, which is a photosensor, meaning it senses light. So it takes the light, transduces it into electrical activity called your action potential, and then the cranial nerve 2 takes it up to your brain, and then your brain will then interpret what you see. That's why magic tricks are so easy, or not easy, but it's very easy to misperceive something, and also just the reminder that your eye doesn't see anything, right? So all those movies that, you know, you get a killer's eye and then now you get to see all the murders. No. The eye is simply a two-chambered, two-roomed globe that all it does is refract light onto this retina. Now, what's refraction? Refraction is the bending of light. And a classic example of refraction is if you've ever looked into like a fish tank and then you stick your hand in it, your hand will look very, very different in like when you're looking at your hand on the outside of the fish tank, because you're looking at your hand through air. But once you stick your hand in water, you know, it gets distorted. Well, that's why you have water here and more like a gel-like substance here, so that all the light rays that get through this opening, which is your pupil, get directed to your retina. Now, if the shape is off, or if it's cloudy, or any of the, like, for example, your cornea, which is your protective layer here, your lens here as well, if that gets scratched up or whatever, it's going to mess with that refraction, and then you're going to have poor vision. Another thing is the shape of your eyeball. For example, I have astigmatism left on my left eye. That means my eyeball isn't shaped like round, it's shaped more like an egg. And that's going to change the distance from where? This pupil to here. So it's going to mess with vision. And that's all that vision is. It's just that for whatever reason, the light doesn't get to the retina efficiently, or something's blocking it. Now, you have these ciliary bodies that have ciliary processes and muscles that connect to your lens. Now, your lens also helps modify and refract that light, much in the same way. Have you ever seen anybody, or maybe you've done it yourself, you play with a magnifying glass, and you know, when it's sunny outside, you could make like a really, really hot point of light by focusing or refracting that sunlight into something that's very, very concentrated. And that, in the same way of how you kind of move around that lens, well, your ciliary body also moves that lens. And as you get older, this ciliary body, this ciliary muscle, it's tired. It doesn't get as efficient, right? So then that also causes some vision issues as well. Now, you could see that this is a living, breathing thing, so it's going to need arteries and veins. And all of that comes, and also the same thing as well, you have all your retina, all of that has to come in through a central spot. And that central spot is called your optic disc, also known as a blind spot. They call it a blind spot because you think of the retina as a camera. So I got cameras all along here, but all the cameras have to be connected into some sort of wire. So I got a camera, and then into the wire. Camera, into a wire. There's going to be a point here where there's no cameras because I have to fit a wire, and I've got to fit arteries and veins in here to go feed my eyeball. Right? Arteries bring in oxygen, right? And veins take out the carbon dioxide. So you have a blind spot, but you could tell me, well, Dr. Garais, I'm looking right at the screen. I don't see any blind spot. Well, let's do this. I think it's on YouTube. Okay. Let's look at this.
Still working at home? Then you need to have video conference lighting. I've been working from home for about a year now, and the
Yeah, I
best
use a
thing I've gotten for
$5
my
light
home
I got
office
from
is video conference
the dollar
lighting from
store.
LoomCube. Whether you're talking on a Zoom call with your coworker.
What you must be seeing on your screen is a dot on the left and a plus sign on the right with a yellow background color. We are going to perform a demonstration to find the blind spot of our eye. Yes, our eye has a blind spot. What is it though? And what does it mean? It is a spot on the retina of the eye where
And
we
that's our
cannot
optic
see the
disc.
light when it's incident on it. I will explain its details a little bit later, but first I will prove its existence to you through an experiment. Okay, let's go back to the start again. Close your left eye and stay still with your right eye focused on the dot. Yes, I want you to stay still and concentrate with your right eye on the dot present on the left of your screen. Now with your left eye closed, I want you to slowly bring your face towards the screen. At some point in time, you will find that the plus sign on the right disappears. Yes, but in order for that to happen, you must focus only on the dot and nothing else.
Okay, did you guys try it? Did the plus sign disappear for you?
Yeah.
Yes. So that means what? You need both eyes for not only depth perception, you need both eyes because your other eye gives the signal for what's missing in the blind spot. So what do you call that? Even in that's one of the first thing they also taught me, well, not only the core, but my uncle taught me when they taught me how to shoot, especially short distances. You try not to close one of your eyes, especially when you're clearing a room, because then your sectors on your right, like for a right-handed person, they close their left eye. Your sectors on the right will disappear. So there could be a bad guy or something on the right. Well, that's why you need both your eyes. So not only for depth perception to know how things are far away or how close they are, it's also so the other eye compensates for the blind spot. Okay. And if the eyes aren't working together, what happens? Okay. When both eyes aren't working in tandem, that's when your patient has what they call a scotoma, which are blind spots. Okay. So that's your optic disc. That's your blind spot. And again, how easy could I do this? A, B, C, D, E, F, G. And if you practice every day for a couple of minutes, then you'll get all the, it'll be the easier portion of the show. And let me say that identification is really heavy on your final exam. And remember the scope of your final exam. It's everything from week 5 onward to week 9. So a lot of the stuff we're looking at, there's a lot of diagrams. So hint, hint, something to look at. And remember, the only thing that the retina does is take in light rays. That's all it does. And then changes it to electricity through your optic nerve. And then it sends it to your brain. So the thing you're looking at right now, it's your brain's interpretation of what's going on. Now, you have night vision and you have day vision. Your rods, which look like this, those are for night visions. They are for visual acuity and also night vision. And also, do you notice when you look at night, when you're walking around at night, you don't see colors too well? And here they have cones because the sensors look like cones. And cones are for day vision, right? Seeing the primary colors, red, green, and blue. And they're also for color. So if you are colorblind, you have a cone problem. If you have problems viewing things at night, you have a rod problem. Okay. And those are all in your retina. Here's your visible spectrum. Remember, you can't see UV light, ultraviolet, nor can you see infrared. It's beyond the scope. And all the colors in the rainbow are just simply combinations of red, green, and blue light waves. And you could see they're just energy. And that's all your eye does is see energy and convert it to a different, transduce it or convert it to a different kind of energy, and then send it to your brain. Sensory nerves, we talked about that. Cranial nerves, no, we want to talk about that. Spinal, nope, we don't want to talk about that. That's brain stuff. So let's look at what we have so far. Did we go over the eye? Yup. Ear, tongue, and taste, nose, and smell. Yup. Here's in your task, a special senses laboratory. Again, don't do the lab, but there's these lovely quick notes that you have here. Okay. Oh, so what's due next week? Task 7, your concept map. Let's see if any hints for the discussion. Discussion 7. Sensory changes can affect an individual's lifestyle, whether they're due to aging, birth defects, or injury. Problems with communication, activities, and feeling part of what's going around them. Because remember, the function of your sensory is to give you input from the outside world and also input from your internal body world, right? So what new technologies? So get something from 2021 that help people, yes, there are new types of hearing aids. Just investigate the latest ones. How about, I guess, how do we deal with people's aging, right? How do we deal with people who are born mute, who can't speak, or maybe because of an injury? And make sure to answer quality of life. And when you do pictures, kindly reference your pictures if you have any. Okay, so very straightforward. That's discussion 7. And let's look at lesson 7. Lesson 7. Oh, look, they're doing a little bit of a special sensors. They do, and we can go over this in laboratory as well. But again, COVID, not allowed to touch each other. Man, this COVID thing ruins everything. Because in the past, I used to show you guys how to do a quick neurologic evaluation, the kind that we would do in the emergency room. But download the case. Part 1. How's this? Part 1, part 2, questions only. Should be good enough because there's a lot of reading on this. Again, I repeat, for lesson 7 case, part 1, part 2, questions only. There should be like 7 or 8 questions total. Okay. So with that being said, it is that portion of the show. Does anyone have any questions? I'll stop the recording.